Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. I'm your host, Dr. Becky Carson, pediatric nurse practitioner and clinical assistant professor at the Catholic University of America in Washington, D.C. And thank you for joining us again in our Acute Care PNP faculty series, co-written and peer-reviewed by nationally renowned faculty from universities across America. This series is designed to build competency in the pediatric acute care skill sets of our current and future colleagues. With content that's founded in the scholarly literature, we put a conversational spin on each topic to help you translate that knowledge into practice. When we focus on what you can do by applying what we know from the evidence to your bedside skills, you can better take care of kids. The best part is that I got to work with my friends, who are brilliant and incredible educators. This episode on case studies for delivering bad news was co-written with me by Dr. Belinda Large from Rush University, Dr. Robin Stamm from the University of Cincinnati, and Dr. Ann Feelauer from the University of Maryland. You can read all about the faculty series, our novel peer review process, and your competency-based education at thepedsnp.com/faculty series. This episode on case studies for delivering bad news is intended to be listened to after the episode on delivering bad news, so that you know the evidence before applying it to the clinical situations in our cases. If you haven't heard it yet, you may want to hit pause and go listen to episode 71, Delivering Bad News, so you can better understand the spikes protocol before we apply it to our case study. If you're all caught up, let's get started. Y'all have heard me talk a lot about my time in Tanzania. When I was in graduate school there, I worked alongside an American physician in a family-based HIV clinic. One of the most memorable days was when we disclosed to a 14-year-old adolescent his HIV status. He was part of our family-based clinic that provided monthly well visits to families who live with HIV. Our patient was so bright, charming, and a little bit shy, with a bashful smile whenever we talked about his favorite things. He was an eager-to-please child and a strictly adherent patient. His mother died when he was a baby, the HIV-negative father remarried, and the father didn't want to tell him about the details of his health status, lest he feel outcast from the family and stigmatized by society. It was an effort to protect him, but it came at a cost. Today was the day we would tell him about the virus he was born with so that he could understand the full breadth of his health journey. We started off the visit with pleasantries. Mambo, poa, hi, hey. Habari za asubuhi, nzuri. How is your morning? Good. Pole za safari, asante. I'm sorry for your travels. Thank you. What do you like to do the most? School. What do you want to be when you grow up? A pilot. We moved into the disclosure slowly, carefully, confirming what he knew about his health status, which was virtually nothing, and what he was ready to hear. He had no idea but was agreeable to listen. We explained that he had a virus called HIV that lives in his blood. We explained the virus as wajuju, bugs, and his immune system as askari, soldiers. The wajuju hurt his askari, which can make him very sick. But we have medicine that make the wajuju go to sleep forever, so his askari will be strong. And if he continues to take his medicine every day, just like he already does, and studies hard in school, just like he already does, he can one day be a pilot. His demeanor was small, shrunken, made even smaller by the stunted growth of his chronic disease. I will not have any friends. Your friends will not know unless you decide to tell them. You do not have to share this information with anyone you don't trust. But I like a girl. If I kiss her, will I give her HIV? Many of his concerns surrounded societal stigma of HIV and trying to understand how it was spread. We spent a long time explaining, correcting misconceptions, offering empathetic support and praise of his good adherence to his medication regimen, and emphasizing his value as a person. At one point, he told us, "I just want to go home now." We respected his wishes, supported him, and reinforced how special he is and how loved he is, and made a plan to follow up in 3 months at his next appointment. That experience was unique for me in so many ways, but also embodied many standardized aspects of delivering bad news that we last discussed in the Spikes protocol. You could apply other evidence-based strategies for delivering bad news, like BRAKES, which is an acronym that stands for background, rapport, explore, announce, kindle, and summarize. Or the ABCDE of delivering bad news. That stands for advance preparation, build a therapeutic environment and relationship, communicate well, deal with the patient and family reactions, and encourage and validate emotions. Whatever strategy you choose, there are nuances and social skills that you must harness to achieve the goals of delivering bad news. You want to understand the patient's knowledge, inform with clarity, keeping in mind the patient's readiness and wants for information, provide psychological support after the bad news is shared, minimize the sense of loneliness and isolation, and develop a treatment plan along with a long-term strategy for collaboration. As our patient populations grow increasingly diverse, it's important to consider culture when having difficult conversations with patients, families, and caregivers. Several studies show that the methods for delivering bad news are based on Western guidelines and curriculum. This calls for us to provide culturally sensitive communication, using skills that are patient-centered, family-centered, and understanding of language, social etiquette, and religious beliefs. Our Tanzanian patients' culture, developmental age, and health literacy were important, especially since our identities differed from his. Our approach allowed time to process and ask questions, used terminology that he understood, and was both honest and realistic. We respected what the patient said, embraced his emotions, provided reassurance, and planned for our future care. Fast forward a few years. I was working a shift in the emergency department when a 7-year-old presented with 10 out of 10 abdominal pain. I reviewed her chart and noticed that she had another visit that day in the special immunology clinic. That was the local term for the HIV clinic. I read the note and found that her HIV status disclosure took place that day. Disclosure happens at a much younger, more ideal age in the United States, but it's still difficult for kids to process. I evaluated the patient thoroughly, took a complete history about the abdominal pain and its accompanying characteristics, and did a focused physical exam. At the end of my exam, the grandmother asked if she could speak with me in the hall. She expressed concern that our patient didn't process the disclosure at the time of the visit, and since developed some symptoms at home that might be psychosomatic in origin. Grandma's hunch conferred with my benign history and physical. I went back into the room and asked her if I could sit down on her stretcher. She said yes, and I asked her to share about her day in the special immunology clinic. The paraphrase of her recollection was that she was going to die, just like her mom. That broke my heart. What an important opportunity to step in and correct misconceptions and re-share her news. So I asked if I could tell her a story about her body and how it works. She looked intrigued and welcomed the explanation. I reached into my pocket and pulled out a few tongue depressors, alcohol pads, and my handy-dandy Sharpie. I drew some puppet faces on the mean Wajuju alcohol pads and happy Ascari tongue depressors. Then we acted out the same scene that I had learned in Tanzania years before, only in 7-year-old language. I gave her the Ascari tongue depressors and asked her lots of clarifying questions as we laid down the alcohol pads and drew sleeping faces on them as they lie flat on the bed. I gave her space through play to make comments and responded truthfully in a way that she understood. Taking her medicine was important, but Grandma was there to help her with that. After a few minutes, I offered some reassurance that I thought her upset tummy might be that she was hungry for a snack. That happens to me too. I dropped off some peanut butter and graham crackers with a promise that I would be back to check on her in a few minutes. And sure enough, she pointed to the smiling 0 face on the pain scale and had a repeat exam that was normal. I empowered her to ask questions, even if she thinks of them later. Her grandma and providers love her and will help her understand. I circled back with a special immunology physician who appreciated the reinforcement of what had already been explained. Sometimes, when bad news hits, patients need a minute to let it sink in, or a puppet show to really make sense of it all. Before we get started on our case, I want to talk about a few ethical principles that are important when talking about bad news and care decisions. Remember, autonomy is self-actualization. It's the concept that each individual should decide what constitutes their own best interest. This means patients have the right to know their medical diagnoses, and with this information, we deliver informed consent for treatments. However, when considering breaking bad news or giving consent for major medical treatment, there were no specific laws that defined age of consent. Technically, when a legal guardian signs for treatments on behalf of their minor child, they aren't giving informed consent because only the individual can do this. The parent is providing parental permission. This is important because it implies a shared decision-making model, where the child may be involved in these decisions, if developmentally appropriate. One Dutch study by Brouwer et al. In 2019 found that parents often disagreed with what, when, and how much information should be shared with their child about their diagnosis. But previous studies indicate that most parents agree that their child needs to be told bad news. Garnering the child or adolescent's permission to conduct the healthcare plan is known as assent. It's time to practice our SPIKES protocol and apply it to a case. Since this is a podcast, you'll hear the application of evidence-based practice. But remember that 90% of communication is nonverbal. So pay attention to posture, tone, and your facial expressions. There are lots of right ways to have this conversation, so you can practice on your own by occasionally pausing the podcast to answer. All right, here we go. You're the pediatric nurse practitioner working in the emergency department, and you sign up for a 6-year-old boy, Jalen, with vomiting. The mother reported that he's been throwing up all day. Triage administered Zofran and started oral rehydration therapy with a bottle of Gatorade. You review the vital signs, which concern you, and when you walk in the room, your spidey senses go off in your pediatric assessment triangle. You immediately notice an altered level of consciousness, Kussmaul breathing, and pallor. You move quickly and calmly to get a tech and nurse to the bedside to draw a couple of labs while you begin to ask a history and assess at the same time. He's been at his grandparents' house all weekend, and Mom picked him up this morning because he had been vomiting all weekend with the stomach flu. Yes, he has been hungry and thirsty now that you mention it. We thought he was in a growth spurt, but he does look thinner. And he does pee a lot, but our PCP told us that kids who are constipated can do that. The results of the bedside point-of-care glucose, blood gas, and urine dipstick are quietly shown to you. Yep, you were afraid of that. Looks like new onset diabetic ketoacidosis. Minutes matter at times like this. So what are you going to do? Thank goodness there's a nurse-initiated pathway that gets those first steps started and buys you about 20 minutes before the next intervention. The nurse and tech give you a nod and step out of the room after completion of their first set of tasks. Now what? How will you create an environment to deliver bad news? What will you say? What will you do? You remember the SPIKES protocol as a template for sharing bad news with families. We'll apply it to the situation here. Setting, patient perception, invitation, knowledge, exploring empathy, and strategy summary. We'll start with setting. Take a moment to reflect on how you will create an environment conducive to sharing this news. Let's start with making sure the door is closed. Pass your phone to your pod buddy who can run interference on any stat results. Dad just arrived. Welcome, Dad. Have a seat right next to Mom. I'm Becky Carson, the pediatric nurse practitioner taking care of your child. Hey, friend, do you mind if I sit here to be close to you and your parents? Okay, the scene is set. Now what? P is patient perception, or in this case, parent perception. What will you say to understand the family's impression of this illness? Maybe something like this. Tell me what you understand about your child's illness today. They say, oh, we thought he had the stomach flu. There were a couple kids out sick in his class last week, so we just assumed he caught it from them. We want to make sure he's well enough to go to his best friend's birthday party this weekend. Dad chimes in, yeah, we just want to knock out anything and get his immune system back up to speed. He's been so sick all winter, poor kid. This is helpful. You now understand that the parents think that the child has an acute illness, not a severe exacerbation of a newly diagnosed chronic disease. This is going to be all new for them, so this is the first of many conversations to come. Now what will you say? That's right, invite them. How can you partner with them in a family-centered way? Maybe something like, would you mind if we talked about the results of some of his tests that came back? You don't mind? Okay, great. Now, are you the kind of parents who want all of the details or a bird's eye overview of what's going on? You just want the big picture? Sure, I'll try to hit only the high points. Great job. You not only invited them, but also got an idea of how they process information and what they want to know. It's time to deliver the bad news in knowledge. But what comes first? How about a super quick summary? I knew those one-liner summary statement skills would come in handy. Maybe it sounds like this. Okay, so before we talk about his results, I want to summarize what's been going on. Jalen is an otherwise healthy child who's had 2 to 3 days of vomiting and increasing fatigue this morning. You've noticed some strange symptoms over the last few months like thirst, peeing a lot, and some weight loss. What comes next in knowledge? You need to divulge devastating information to them. Are these the kind of people who will benefit from a warning statement? Or will it derail their ability to hear anything else? Maybe somewhere in between? How are you going to phrase it? How will you explain DKA in layman's terms? You give it a shot like this. Unfortunately, the tests that we've done show that this is likely type 1 diabetes and your child is in a state called diabetic ketoacidosis, or DKA. You pause to give them time to process. Mom starts crying. Dad's mouth drops open and he puts a hand over it. Mom tearfully asks, "Are you sure?" Yes, his blood sugars are well above 500, which is very concerning, and his urine shows large amounts of ketones, which tells us there's acid buildup in his body. His pH has an excess of acid, which tells us we're sure about the diagnosis. There are other labs that we need to review to get all of the information, and today is a lot about information gathering. Luckily, you brought him in early, and it looks like there's not too much of that acid built up where we would call this acidosis severe. But we need to do a pretty involved process where we give him insulin and help balance the sugar and fluid in his body until we can get his acid balance to a safe place. I know this is a lot of information. Tell me what questions you have so far. All right, pretty good job. You paused, you clarified, you gave space for questions. Nice work. Let's keep it going. Mom asks, How long will it take to fix him? Are we going to stay here tonight? I just want to take my baby home. Is he going to die? Whoa, that is a lot of emotions coming at you all at once. It's okay. You expected that, and you are cool, calm, and collected. They are understandably stressed, so your calm demeanor is important. Be clear, be honest, be direct, and don't give promises that you can't keep. How are you going to respond? Time for the E in spikes, empathy. Stop and validate the emotions. Use empathy to recognize the emotions and give them the freedom to have those feelings. What could convey empathy here? How about something like this? This is extremely difficult to hear. I know you're very surprised, and it's a lot to take in all at once. Jalen is very sick, but he is stable. How are you feeling, buddy? A little bit better? I'm glad to hear that. Does your head hurt at all? No? Good. He's going to spend a few hours down here in the emergency department while we start the fluid and insulin protocol. He looks well enough that we don't need to do any brain imaging right now, but we're going to keep a close eye on him. After his treatment is started down here, we'll spend the night in the ICU where one parent can stay with him at all times. He'll have a nurse who stays awake overnight to make sure his sugar and insulin levels are right. Diabetes is a chronic disease, and he's going to need medicine to help manage it every day. You're going to meet a lot of people over the next few days who are going to help you with the acute illness, but then we'll help you transition to a routine that he can go home with, and there will be another team of endocrinology providers that manage his care long term. Phew, that was okay. It was a lot of information. You introduced the idea that there will be many conversations to come, and there will be a team-based approach to care. Don't try to do it all right now. Remember, you have labs to manage. But you can't rush a big conversation like this. How can you ensure that the whirlwind of emotions and questions that the parents have are validated and addressed? What are the next steps for the family? For you? Good thinking. Finish up spikes with your second S. Strategize and summarize. How are you going to do that? Lay out what to expect in the coming minutes and hours, make a plan to reconnect, and don't forget to talk to your patient. He's listening. So maybe something like this. The next steps are going to be to get a second IV, finish some rehydration, and start his fluid and insulin protocol. Once his labs normalize a little bit and we have a bed upstairs, we'll walk you up to his room in the ICU. You'll meet the ICU team, and the endocrine team will meet him tomorrow morning. I know this is a lot of information to get all at once, and I know you'll have tons more questions before the day is done. Please write them down because we want to answer all of them. Maybe make a note in your cell phone, and we'll talk with you whenever anything comes up on our end too. Hey, Jalen, Mom and Dad are here with you, and someone is going to stay with you while you're here. Do you have any questions? Yeah, buddy, you do need another IV. I know that feels scary and you don't want to get one, but I'm going to get my friend from Child Life to come in first, and she can help you with Freezy spray and a Buzzy to help make it easier. I'll check back in on you in a few minutes, okay? Here comes your nurse. All right, I'll be back soon. You did a great job using empathy and your expert pediatric acute care knowledge to provide information and support to this family. The nurse can be the support person in the room now that you've finished the conversation, and Child Life is great in this role too. It's never easy to be the bearer of bad news, but it's a skill that you can practice to make it easier on the patient and caregivers. As we finish the episode, I hope you'll listen to the next few episodes that are all about supporting your well-being and resilience. We have a hard job, which often requires us to journey through our patients' most vulnerable human experiences. If we're to navigate them safely on this journey, we must also care for ourselves, or we're doomed for burnout and compassion fatigue. I need you. The kids need you. In this profession. So do me a favor and earnestly listen to what I tell you at the end of every episode. Take care of yourself. I hope that you'll like, comment, and subscribe to the Peds NP, where we discuss the practical application of evidence-based practice in a conversational way that helps you synthesize and transform the best practices from the literature into your clinical bedside skills. Thanks to the acute care PNP faculty who supported the creation and review of this series, especially my co-authors on this episode, Drs. Belinda Large, Robin Stam, and Ann Feelauer. You can read all about the contributors and see show notes, references, competencies, and our peer review process at thepedsnp.com/faculty series. Share it with a colleague, pass it along to your classmates, text it to a friend. There's no financial support or conflict of interest in this episode of the Peds NP. Follow me on Instagram at the Peds NP podcast. Email me at thepedsnp@gmail.com. And remember, this isn't just a podcast. The Spikes protocol can help you sharpen skills for delivering bad news. I'm Becky Carson. Take care.